Morning. I'm Dr. Horace Cox. It's a pleasure to be part of this. Welcome once again to another roundtable discussion for the Guyana Mental Health and Wellbeing Conference. My sincere apologies for being late, but it's a struggle at times with technology, but it's a blessing nonetheless. Having said that, I'm happy for us to make a start this morning. We have quite a distinguished panel. First off, we have Dr. Penelope Sieber, who is a senior lecturer at the Nottingham Trent University. She lectures in health and social care and is interested in how theory is used in practice to support the design, implementation, and evaluation of interventions aimed at improving health outcomes and reducing inequalities. She'll be followed by Dr. Dwayne Edwards, who is a senior lecturer in the Department of Sociology at the University of Guyana. His research areas include ethnic dynamics in plural societies such as Guyana, the social implications of Caribbean philosophical and development thought, and sociocultural systems in developing societies. Dr. Edwards will be followed by Mr. Matthew Harrocks, who is an assistant professor of mental health and psychological therapies at the University in Nottingham. Matt holds qualifications and professional registrations in cognitive behavioral psychotherapy and person-centered experimental counseling. And lastly, on our panel today, we will hear from Ms. Ayodele Dalgety-Dean, who is the founder and director of the Blossom Incorporated that works with children and families affected by sexual violence and exploitation and refugee, migrant, and host communities. Her mission is to eliminate sexual and gender-based violence against children and women in the society and making mental health services accessible to every child. So today we're roughly here for 50 minutes, and to say that our title for this round table discussion is Suicide Prevention, Learning from Sociocultural Perspectives to Create a Sustainable Community. I now hand over to Dr. Sieber. Thank you.
Good morning, everybody. I said hello before, and it's lovely to see you all, and to those in the room and online. Now, I'm going to start off this this roundtable discussion, and we really do want to generate a discussion. So some of my slides, what I'll put together is just to do that. Now, one of the things I wanted to just to add to your introductions, Dr. Cox, was that Io is also my PhD student, and I'll just talk a little bit just before to introduce us and who we are and how we came together. So I came to Guyana, I grew up in Guyana, and I've been away, and I came back and visited about 4 years ago, and had a discussion with people and some friends and catching up, and realized that suicide was a real issue and had so many questions. As a result of that visit, I met up with Dwayne, Matthew Horrocks, and we started to have some conversations about exploring and trying to understand why, which seems to be the key question presented to us from the keynote speaker. As a result of that, I managed to get a little a PhD studentship together, and to my delight, I was selected as a candidate, and which was wonderful because it's someone who is from Guyana doing research on Guyana for Guyanese. So for me, that was very important. So going on to what I want to talk about. We call Guyana the land of many waters, but I want to add that it's also a land of many spirits. And, you know, we can start to discuss that as we go into into the discussions later. I don't know if anybody recognizes this, and I can't see at the moment while I'm talking, but when I visited, I spent all my summers with my grandparents in Berbice, and we used to walk down and come across this building. And at that time when we were children, it was seen as a scary place. And I believe it was the old, what was then called the old asylum. So again, you know, situating some of the beliefs, even in early childhood, around mental health, around the stigma with mental health. And it was interesting to see this building after all this time. But coming on to the real meat of this discussion. And I'm not going to read this, but I think this is an important statement by Franklin. And also, I think what is also important is the other statement below. And it's about how we situate suicidality, as well as looking at where this takes place on a global scale. And we saw some of those facts and figures on Monday in the keynote speech, and which I found particularly interesting in the distribution. It was also interesting because what I realized from that talk, that there is a wealth of information, the wealth of epidemiological data. And I think this is where we come in with our perspectives. So starting off with, I was saying that, you know, when I came to visit, I met up also with Dr. Henry. And we had some discussions, but both Dr. Henry and Dr. Edwards have produced some important papers looking at Guyanese and looking at suicide within the Guyana context. And, you know, I urge you all to have a little look at those papers. I've put the references at the bottom. But these were the key things that came out about religious beliefs and witchcraft, which is something that I wanted to pursue. So we wanted to look at this in the context of the current research context, where we know now that there's a wealth of research that takes a very biomedical approach, but also looks at, you know, understanding the patterns and distribution. So we think there are other things that needs to be looked at. So we take what we call a critical suicidology lens, and I'll explain here in the next couple of slides. And what is this? It's the integration of the cultural, philosophical, religious, and spiritual thinking. And in preparation for this today, I was exploring this paper, which is looking at the role of anthropology, because I'm interested in understanding some of the more cultural determinants and spiritual determinants of suicide and suicide ideation. And one of the things I think is important, and the emerging literature in this, and in this emerging area of suicide research, is trying to use approaches to explore meaning, personhood, and agency, and starting to delve into things a little more deeper. And I think you'll get some of that when you hear Dwayne and Ayo and Matt talk about their research and their interests. And importantly, it's drawing on the work of, and now I'm not going to be able to pronounce this, I think it's Helmlad. And if someone can help me with the pronunciation, I'll be most grateful. And the work of White. And they have put some interesting, and sometimes, as I read around it, provocative discussions about the way we should be approaching suicide research, in particular, looking at it from a socio-cultural perspective. And for us, and for me, growing up in Guyana, and I will touch more on this just now, is looking at the insights and understanding of this complex relationship between culture, spiritual practices. And one of the areas that I was really interested in is around rites and rituals, particularly associated with certain spiritual beliefs and deities. And we'll get onto that in a minute. So, you know, when you want to talk about these things, you need to make sure that you have very good references, as I tell my students. And I decided that the Lancet is a good place to start. And there are a few good articles in the Lancet actually promoting this idea that we need to have more integration around cultural perspectives looking at health, particularly culture and health, mental health, culture, and public health, so that we develop and create interventions that have that are more meaningful, both in at a cultural level as well as a spiritual level as well, because we do need to understand how these all integrate. So very quickly, I gather I'm probably running out of time. What is the nature of the relationship between culture, spirituality, religion, and suicide in Guyana? And that's one of our main overarching questions in the research that us as a group wish to undertake. So we start with some questions. I think everybody is quite familiar with this statue. I remember when it was first put up in Guyana, and I won't say why a lot of us found it very hilarious when we were young, growing up as young adults. So here are some of the questions. And I'll be really interested in people's view of these when we come to the discussion section. And I just wanted to touch very briefly on the religious landscape. And now we can't go into very deep discussions about that. And I believe after this session, there is a session that's going to be touching on some of these. But these, you know, some of these pictures reflect the diversity in Guyana. And then for me comes after what I would call the more formal religious practices, we have all what I call the informal, the folk tales and the spirits that live with us in Guyana. And I was just going to play this because this is the sound from my childhood as storytellers come together to call people to listen to stories.
There is a meeting here tonight. There is a meeting here tonight. Come one, come all and join around. There is a meeting here tonight. Wabilia can go. Wabilia can go. Wabilia can go. Another generation come.
And again, another little story. Take a few seconds.
Oh, like it's an old woman, right? But when night time comes, she just take off this skin. And she's torn a ball of fire. And she's flying through the air. And she's whipping the people's house through the keyhole. Whoops! And she just find the baby with life. And she just lift the sheet. And then she just make the puncture with shit. And she just suck the baby dry. Yo, it's true.
So I just put this as a clip. I don't know if anybody knows what that is. That happens to be my father. So I grew up listening to all these stories, and it's quite interesting because I had some conversations as I was preparing for this. And I was told, yes, that, you know, some of these stories are still going around. Some of these beliefs in Old Haig and the different spirits are still there. And this brought me on to a most recent study carried out by a Brazilian colleague. I don't know if anybody recognized this, but we used to call it the halfway tree. But the studies by Marcelo, he's done some ethnographic work recently, and linked to his study is this tree. And what he was told was that this tree has to stay there because if you try to cut it down, people who ever try to will die because, you know, this is a possessed tree. It's possessed and guarded by the Dutch spirits. And he then goes on to find and discuss with people about possession of individuals and how the Dutch spirits are in control of their lives, as well as when they decide to live and when they decide to die. Now, this was a study that's just recent, and this paper is coming out. But I think it's important that we understand that there are different, what we call ontologies, different realities existing still in contemporary Guyanese society. And this is important for us to take into account when we start to think about suicide and suicide ideation. And this is just a picture of Kali, and this is some of the interests that I have and wish to explore as sometime in the future. And this is what I'll end with. And here are a list of references. Thank you very much.
Thank you very much, Dr. Sieber. Very interesting discussion. For the colleagues that have tuned in, please, I've placed in the chat that you can place your questions there. We'll entertain those at the end. We now transition to Dr. Edwards. Thank you.
Good morning once again, everyone. And let me share my screen. Just confirm that you are seeing my screen, everyone.
That's right.
Where am I?
Lord, we don't know. Everywhere.
Just a minute. All right. Where am I? Good, this is it. Yes, just confirm once again.
Yes, I can see.
Good. So good morning once again, and was stated earlier, the title of this panel and my presentation specifically is Suicide Prevention, Learning from Sociocultural Perspective to Create a Sustainable Community Response. I learned from my experience in presenting at conferences that it's important to state your thesis at the very start of the presentation, rather than in order to take an anticlimactic approach. So even if time runs out, the main statement that I want to contribute is already stated. And in this case, the thesis I'm putting forward here is that from a sociological standpoint, suicide is influenced, no doubt, by a complex interaction of factors existing on 3 levels of social reality. However, in the context of Guyana, the meso-level cultural factors are key in both understanding and effectively responding to suicide as a national social problem. What are these meso-level cultural factors? And I must explain here, must make clear that I'm not referring specifically to the contents of any culture or any cultural subsystem, but I'm referring here to the ambivalence created by competing cultural subsystems. And what do I mean by ambivalence? By ambivalence, the term as used here draws attention away from the contents of norms and values within culture and places emphasis on the fact of a conflict of values or conflict of norms between competing social or cultural subsystems. And I'll explain as I go down. To make my point or to substantiate my argument, what I present here are some data collected or obtained from the Ministry of Health between the years 2003 to 2007. And the data is disaggregated across by regions, disaggregated by ethnicity, disaggregated by age, and so. What we're seeing here is that in terms of raw numbers, in terms of frequency, between the years 2003 and 2007, the regions with the highest number of, or highest occurrences of suicide were regions 4, 6, and then to a lesser extent, regions 2, 3, and 5. When we looked at the data in terms of suicide rate, suicide occurrences for the occurrence of suicide per 100,000 persons by region, we see that region 6 has the highest suicide rate, which is followed by region 2, and then 3, 5, and 4. When the data is disaggregated by ethnicity, however, a very telling fact reveals itself. Suicide occurs predominantly among the Indo-Guyanese population, and that's a telling fact. And also, although the data that I just presented there was between 2003 and 2007, recent data provided by the Ministry of Health also shows that the realities that I've established by those, the facts established by the data, perpetuated themselves even up to 2020. I haven't seen data on 2021. 2021 is not closed as yet. We're near to the close, but it's not ended as yet. So the most recent I have is up to 2020. And this SPY shows that almost 70%, 68% specifically, of the occurrences of suicide in Guyana occur among the Indo-Guyanese population. In terms of the age distribution, we see that the age group between 15 to 29, that is the age group with the highest occurrence. And then there is some gap, and then there is slightly lower, but still significantly high amount of suicide among the 40 to 49 years old demographics. So yes, so before I go into that, the data establishes some significant facts, and the facts that are established by the data is that, one, suicide occurs predominantly among the Indo-Guyanese population, in some cases almost exclusively, and it's among the Indo-Guyanese male between the ages of 15 and 29. So one, the rate is high among Indo-Guyanese. Secondly, it is high among Indo-Guyanese male. And thirdly, it's high among Indo-Guyanese male youth. So this begs the question, what are the factors that are dominant within the Indo-Guyanese cultural system that feeds into that high tendency of suicide rate among the population? And I was influenced by Durkheim's theory of suicide, in which he teased out the relationship between levels of social integration or social capital within a society and suicide rate, and also the level of regulation within a society and suicide rate. And he came up with a classification of different types of suicide based on the different levels of integration and regulation, and which is represented here by this diagram. When integration or social integration or social capital is low, we see what is called egotistic suicide. When it's high, we see what is called altruistic suicide. When regulation is low, we see what is called anomic suicide. And when it's high, we experience what is called fatalistic suicide. So guided by this analytic framework, I went on to analyze some other data related to levels of social integration within the different communities in Guyana, the different ethnic groups, and the different regions, as to see to what extent variations in social integration or variations in social regulation operationalized here as norms and values and so forth. To what extent there are relationship between these variables and the suicide rate as proposed by Durkheim. What I have here is a table displaying different dimensions of social integration and suicide rate for all 10 regions. Interestingly, and the data that is used to arrive at these calculations were sourced from the National Census 2002, the Government of Guyana Poverty Reduction Strategy paper in 2011, and GCOM's voting record for the 26th election. And what we've seen, the regions with the highest suicide rate, 2, 3, 4, 5, and 6, also are also the regions with the highest level of political integration and also the highest level of social integration. It's the reverse, however, for religious integration. So, coming back to Durkheim, Durkheim argues that when there is a breakdown in social integration, we see manifest what is called egotistic suicide. But according to the data, the political integration, social integration, both dimensions of social integration broadly, or societal integration broadly speaking, are very high in the Indo-Guyanese community. So the type of suicide that we're experiencing or seeing is definitely not egotistic suicide as postulated by Durkheim. There's no breakdown in social solidarity or social capital among Indo-Guyanese group. In fact, it is the very opposite. Suicide, therefore, cannot be categorized as egotistic suicide. And this has important implications for policy and intervention. The tools that we use to treat someone whose behavior arises from a sense of loss, loneliness, disconnectedness from the larger community or society or ethnic group might be different from the tools we use or from the tools that are required to intervene in behaviors influenced by other factors. So it's important to know what are the factors that are influencing this high rate of suicide in order to inform our intervention. So what I've seen is based on empirical work done by Dans in 2004, George Dans in 2004, in the research report that is known as the title of which is The Shadow of Death, and by current research by our colleague that is right on the panel here, Dalgety Dean, our work is forthcoming, but there's a similarity that runs across the different studies. And one of the main factors that contribute to the suicide rate based on the data they collected is family problems. So that led me to ask, what are these problems within the families that are influencing high levels of suicide rate among the Indo-Guyanese population? And I postulate here that the cultural norms of the Indo-Guyanese cultural subsystem are at odds with the larger Creole or globalized cultural system. And I've identified two of these for discussion, but there are more but the time does not allow us to really get into some of them. Let's deal with the norms of collectivity and which are expressed in the need by the parent to dictate to children issues related to various aspects of their personal lives, and more importantly, choice of partner. Also the norms of achievement. The combination of these norms result in conflict between the older generation or parents and the forthcoming or younger generation, children, because children now are living in a global society that are based on values of individuality and freedom and so forth. And those values are competing with values of a very closely knitted community where parents still desire to preserve the privilege of directing and dictating what happens in the life or the future of their children and at a very high level. So what we are seeing here, as I'm postulating, is that the younger generation are rebelling against the diktats of the older generation. And this is occurring within a context of political, cultural, economic competition in the larger social system. Because the larger social system, we would know that Guyana is an ethnically plural society. Because of the competition among cultural, political, and ethnic units in the larger social system, the old generation or the old generation sees it as their responsibility to dictate or to guide the younger generation and to equip them with the tools that are necessary to successfully navigate this competition. So, which would explain the norms of achievement. Parents would place a high amount of pressure on children to achieve in various aspects of their life, especially financially, educationally, and so forth. And of course, parents place a high degree of pressure on children with regards to their choice of partner. And this, I haven't shown the slide with the breakdown of suicide rate across genders. The suicide occurs predominantly among the Indo-Guyanese male. So that pressure is brought to bear more on the Indo-Guyanese male than the Indo-Guyanese female. So this brings us back to Durkheim and his analytic theoretical framework. And having said what I said, how does this, my postulate, fits into Durkheim's theory of suicide? What we are experiencing, as explained before, is a situation where in the Indo-Guyanese cultural subsystem, we have high degree of, or high levels of social integration. And we also have high levels of relative, and these are, I'm speaking here in relative terms. And we also have high levels of social regulation. And as I explained before, social regulation operationalizes or expresses itself as norms and the values that the generation before imposes on the emerging generation. So what we're seeing is not fatalistic suicide, which results only from high regulation, or altruistic suicide, which results only from high integration, but a combination of two, and which I want to refer to as defiant, a kind of defiant suicide, where the young generation, as according to the data, it's primarily the youth between 15 and 29, that young generation is faced with an ambivalent situation, faced with a certain pattern of socialization in the family and maybe by extension the community, but they're caught up in a larger cultural context that is influenced by values and ideas about freedom, individuality, and personal choice, and so forth. So that ambivalence at times and the pressure that is brought to bear from family result in a situation where the youngsters are forced to rebel, and they rebel in some choose to rebel in a very fatal way, but also in a very defiant way. So what we are seeing, according to my postulate, is a type of suicide that I would want to refer to as defiant suicide. And if this is the case, then we must reconceptualize the ways, the intervention strategies It's not egotistic suicide. So the clinical psychological approach by itself might not be sufficient. I've seen in terms of intervention, the government before this current regime as doubling down on providing call centers, help hotlines, and so forth, so that persons with suicidal tendencies and so forth could call and get counseling and so. And from the data that I've seen, many persons are indeed calling, but apparently the suicide rate is not being positively affected, which means that we have to rethink our intervention. We have to supplement our current approach to intervening with other approaches. And those approaches should happen at the level of the family in combination with the counseling that we're already providing. We should have maybe workshops in community conflict resolution, anger management for both parents and children, and for partners, because there's another category of suicide that I haven't touched here, but maybe Dalgety Dean will touch on, suicide that results from relationship issues. Then we might also have to think about intervention at the community level. Victims need to be assured that they are helped outside of the immediate family, and there should be groups within the community, such as the extended family, the community organization, religious organizations, that persons can turn to in the event of having problem with within their family structure. So we need intervention, of course, at the level of the individual, which I think is already being provided, but we also need intervention at the level of the family, at the level of the communities, and so forth. And lastly, which is a more radical approach, but it's just here for discussion. I can remember a couple of years ago when Professor Mars was murdered by a group of teenagers. The Child Care Agency argued that we might have to start holding parents accountable for delinquent behavior that leads to these kinds of outcome. And maybe it's up for debate. Maybe when we see cases where youths are forced to take their lives directly on account of behavior or actions by the parent, we might have to start thinking about holding parents to account. It's difficult, but it's up to debate. Thank you very much.
Thanks so much, Dr. Edwards. Time is against us. It's developing well. Now we transition to Mr. Rocks. We have probably another 30 minutes, and I'm sure we'd like to get in some questions at the end. So it's a challenge for us that remain to manage it as best as we can. Mr. Rocks, all over to you. Thanks.
I'll try and be very brief. And picking up where Dwayne left off, I think the key point I'm trying to make with my presentation here is that when we're working with people who might be suicidal or expressing suicidal thoughts or plans or intent, it's listening to what they're saying. That sounds very simplistic, but it's listening to what they're saying and what the meanings that suicide might have for them. As people have put in the chat, are they trying to escape something? Is there a belief in reincarnation that they'll stop this life and come back? It's about tuning in to what suicide means in their phenomenology, their meaning, their life world. So that's really the key points I want to start with today. Are you able to see my slides? Can we see this? Can somebody let me know if you can see my slides?
Yes, that's right. I can see it. Right.
Thank you very much. So I was really interested in this idea about how, as mental health staff or doctors and clinicians, work with people who are suicidal, and how we might key into the meanings of suicide for people. And I was focusing my research on what in England we call general practitioners. The system of care is configured as such. In England, we have primary care, secondary care, and tertiary care. Primary care is the most accessible service. It's community-based clinics that cater to defined geographic areas. staffed by family health doctors, what we call general practitioners. In the United States, might be called community physicians or primary healthcare centers. Also supported by practice nurses, healthcare assistants. And these clinics make extensive use of computerized recording systems. So I was interested in how much of the patient's phenomenology and life story and life world discourse might be within those clinical systems, but not being picked up to inform care particularly. And we know how across transnational studies, going back to 2002, so it's quite out of date now, but it was a landmark study of its time. It was a review of suicide rates after contact with community clinics, such as primary care. And they argued that 45% of people took their own life within 1 month of contact with a community clinic. So primary care or community clinics have a key role perhaps in suicide prevention and working with people on that pathway towards risk. But when we think about primary care settings in the UK, we know that the content of clinical note system are really varied. You know, some will have very precise recording of suicide risk. Others might record depression or low mood or something else, but not actually say that the patient was talking about ending their life. And compounding that, doctors here in the UK have no standardized approach for working with suicide risk. Some doctors have interest or knowledge in this area. Others, it might not be something they've really encountered and haven't had any training on. We know there are problems with using suicide risk assessment tools in terms of their positive predictive validity, particularly in the short term. They can't tell us if somebody's likely to go and attempt suicide in the near future. They can give us an informed guess is about the extent of the science. And we know that such tools are actually unlikely to be used in primary care in the UK. Doctors have 10 minutes per patient. That's what they're funded for, 10 minutes per patient. And the time taken to score, interpret these tools often takes longer than that. There are also licensing issues that you're supposed to pay a fee to use many of these tools. So doctors have said, well, why can't we try and leverage the computer to help us with this, perhaps looking at the data we've got about clients' histories, or looking at sort of giving us some prompts, things that we could ask the clients, the patients in session. And this is really important. This is the key point I'm making, I think. Doctors in the UK are phenomenally busy, funded for 10 minutes per patient, and we're seeing a huge increase in demand on primary care doctors in terms of the waiting lists, the workload, dwindling resources. It's a really pressurized system. And perhaps as a consequence of that, it's possible that sometimes doctors are thinking in the professional language of medicine, so looking for signs and symptoms of disease or medical conditions like depression, or framing suicidal ideation as suicidal ideation, you know, clinical terminology, clinical language. And what that sometimes might result in is doctors asking patients about suicide in quite a sort of clumsy way, saying things like, you're not thinking of suicide, are you? This is what linguists call phrasing questions with negative polarity. That predisposes clients to answer, no, doctor, I'm fine. And it could be that that's just a sort of a relatively clumsy expression born out of high pressure and high workload. Or it could also be that this is a tacit collusion to let's not open up this very thorny, complex topic of suicide right now. And we know patients, when they present to primary care, they like to present distress as somatic rather than emotional. They don't like to come to doctors and say, you know, I'm having problems with my emotions and my psychology. They'll come with back pain or something else. And people like to use natural terms when they're talking about suicide. If you look at sort of the content of suicide letters and so on, talk about ending things, escaping things, doing myself in. So we have this difference in how people might be conceptualizing and talking about suicide. And I was interested in my study looking at Habermas, Jürgen Habermas's theory of communicative action. He argued that society is split into what he calls the systems world. So this is the world of the economy and the state and the functions of society on that macro level. And the life world, which is the phenomenology, the language, the way that we communicate as neighbors, as friends, as colleagues, as human beings. And Habermas was interested in the way that the systems world seeks to overcome the life world, a bit like Dwayne was saying, you know, the approach to suicide prevention, putting up things that are looking at the egoistic suicides, but maybe neglecting some of the other parts of that framework. So the system world tends to influence the life world, not always in a good way. And it's been argued medical practice is part of the systems world, the medical terminologies, the diagnostic criteria and so on. These are artifacts of the systems world that sometimes we try to impose on people's natural experience. And the key point I'm making is that we should try and think about when we're working with clients and patients, finding that middle ground between the clinical language, clinical terminology, and the patient's phenomenology and reality. And my work was trying to design a computerized tool to sit in the middle. I can tell you some more data about how we got on with that afterwards, but I think I'll stop there and leave time for Io to present some of her work as well.
Thanks so much, Matthew. You're too kind. Io, all over to you.
Okay, and I will try to round everything up nicely for our group. So as Penny mentioned, I am a her PhD student. And I think when I'm going to focus more on the data that I've been collecting so far, just so that I can be very quick. Right, let me try to share my screen. Let's go. Oops. Right. Sorry. So I will go for more of a narrative approach. So I can't see anyone, but I'll try to go through things quickly. Okay, the hangman does pass through, starting in November, said a member of the focus group I was holding in Barometer. And so it was, Blossom's telephone rang to say that 5 persons had died by suicide in Barometer by the end of the first week in November 2021. And this is exactly why my research is focused on exploring the cultural and social aspects of suicide in Guyana. And this is why I am journeying through my suicide research ethnographically. This means that I was embedded or immersed in the field where I learned from all stakeholders about the formal, informal, and taboo discussions around the narrative that perpetuates suicide in Guyana. I held focus groups with grassroots persons, school-aged children 15 and over, the police, politicians, civil society organizations, nurses, doctors, accountants, teachers, judges, social workers, priests, imams, pastors, swamis, civil servants, lecturers, husbands, wives, pilots, engineers, childcare professionals, entrepreneurs, everyone. In the field, I did not struggle to recruit participants, which was actually rather surprising for me. Everyone wanted to talk. Is this because suicide affects everyone? And here in Guyana, thus far, everyone I've spoken to knows of someone who has attempted or died by suicide. And indeed, as we know, the World Population Review in 2020 stated that 40.3 in every 100,000 persons die by suicide in Guyana. Now, over the past few days, we've gone through the various versions of the medicalized approaches to suicide and suicide prevention. But yet, as Professor Hoven asked on day 1 of this conference, why does suicide have such a grip on this nation? And we all know the stats, and I don't think I need to go over it all about it's demonstratively prominent amongst our younger generation, et cetera, We know all of this. So for me, something different has to be done, and something different must be done. So that's where really the ethnographic approach is absolutely necessary. And Reeves and all in 2008 and 2013 made known that ethnography, qualitative research, and I quote, gathers observations, interviews, and documentary data to produce detailed and comprehensive accounts of different social phenomena. So it is through the interview process, the participants were given a chance to articulate a myriad of details that provide insights into the factors that underpin an ethnographic inquiry. So given Guyana's social, geographical, political, and historical complexities, I was kind of adamant about the importance of the application of these methods in this affair when looking at suicide. The literature in relation to the causes for the high cases of suicide in Guyana is kind of replete with the phrase mental health. However, as Penny mentioned, as Dwayne mentioned, there must be more. And if we are to stake a claim to be cautious, basically, in devising solutions to ending suicide and suicide ideation, the magnitude, scale, and scope of this perennial problem must be matched with the most efficient data gathering mechanisms. In this respect, ethnography ensures one speaks to participants within their social settings and getting a gist of how their culture is created. So where am I now? I've just finished my data collection and I'm marinating on some extremely rich data. I've done 14 focus groups with over 140 participants. I've had over 120 key informant interviews. I've got my field notes and my observations. And I'll share with you now some of the direct quotations and extracts of the language, themes, patterns that are coming out of my data collection. And I want you to think back to when Penny mentioned meaning, personhood, and agency. And I will read exactly one of the extracts on views about suicide. This is a participant. Too complex to explain in a line or two. Here are some hints. People of sound mind and body and fully self-aware and socially aware are entitled to end their lives if it becomes too hard to bear. But it should be regarded as a final option and a choice which they always hold in reserve but never actually use, knowing that it will always be there if and when needed. But most young people are unaware that bad times will pass. I always found the acronym HOPE, H-O-P-E, hold on, pain ends, to be useful. And more should be made of it in an ongoing, sustained manner with persons, especially young people and males. Suicide is one of the ways, albeit a terrible way, of letting the society know how so many are in pain and will go to such lengths to end their pain. There is also quick and slow suicide. People who slowly drink or eat their ways to death, or those who shoot, knife, or drink a known poison. Need to differentiate between known poisons like alcohol, sugar, and other substances that advertise themselves as poisonous. At one point in my life, when I had all of my close friends together in the same place, I can't remember what triggered it. I wasn't feeling suicidal, and in fact, have never felt suicidal. But I told them that if I ever killed myself by way of suicide, I didn't want them feeling embarrassed or feeling the need to explain or exculpate me. They should know that I was using an option always available to all of us. This is what lets us know that we are in control and can handle anything life throws our way. So that was one participant. Another one said to me, in my opinion, suicide is often a last option for many persons when they are in situations where they feel shame, they cannot endure any further pain, hope to preserve honor, or in some circumstances, it may be sacrificial. I would not say that suicide is right or wrong, but it has a strong grounding in one's personal, religious, and cultural belief. And as such, since humans have free will, they are capable of taking their own lives. It will always be an option some would choose, simply because they can. Then another participant, my view on suicide is based off of religion, where it is stated that one should take my view on suicide is based off of religion, where it is stated that one shouldn't take his or her own life. Even though I recognize it as a fundamental right of a person, I see it as a one-way ticket to hell. Then with some participants, we went on to talk about why people might die by suicide. And one said to me, because they lack hope and feel like they have no other option. I also feel that several victims of suicide have seen it happen and perhaps have that stored in their minds from childhood as a way to escape their problems. I then went on and I had so many conversations. And again, I'll just quote directly from the data that I collected. We're talking about the beliefs about where the idea to die by suicide comes from. And I'll just list some. One, I think that people have been committing suicide from long ago. However, I don't know where that idea came from. Two, the idea to commit suicide comes from within one's own head or thoughts. Three, from past experiences they knew. Four, it was normalized in homes since before I was born. I grew up hearing it was a tonic for the Indo-Guyanese. 5, it is an age-old universal issue. It does not come from any particular ID. 6, it comes from domestic oppression. 7, it is inherent personal thoughts. Another participant, 8, passed down from generations. 9, not sure. Some seem to think it's a cultural thing amongst Indians, part of their religious setup. However, there has been enough murder-suicides to suggest that dealing with grief rage is a major challenge for males. 10, think it's cultural, also a learned pattern. 11, I can't pinpoint specific issues, but the elderly have a role to play in such activities. Another one said, spiritually, it can be the devil invading our thoughts. And I'll stop here on the last one because when I was running this focus group, I had to put my pen down at this point. One person looked me in the eyes and said, only strong people commit suicide. And I end on that note for discussion. And if anyone would like to have some references, please do contact me. Thank you.
Yes, thanks so much. Thank you so much, panel. I know we have to wrap up. We've gone over time, even though the colleagues have been gracious to give us some. So we have 2 questions in the chat, but I'm just wondering whether perhaps we can give 30-second responses. The first one is from Nicole Cole. She wanted to know whether the research investigates the link between reincarnation teaching and suicide. What are your thoughts on euthanasia? Is this form of suicide any different from those occasioned by religious and cultural beliefs? One person to answer, 30 seconds.
I'll answer very quickly. Sorry, I'll start my video in 30 seconds. As we pointed out, this is an emerging area. And one of the things that we are keen to do is to develop this collaboratively with communities, with people. And this is part of IO's intention as well as ours. And I think for me, this is all questions, as I pointed out, that we have to answer. And this is the emerging approaches that we'd like to take to enable those questions to be answered and explored.
Thanks so much. The second is from Maritza Mansfield. This is the last question that we'll entertain for now. How can a parent that is having these kinds of issues deal with their own kids when they can't help themselves?
Yes, and again, I think we are aware of that. And I think IO, in a way, her research is focusing on that and exploring. And as I said, taking this, this critical suicidology lens allows us to start to examine these issues in more detail at a different level. And I think sometimes the current research approaches sort of don't allow us to do that. And I think this is the value of taking this approach. I don't know if Matt has anything to add quickly.
I mean, yes, I think it's a really complex phenomenon, suicide, and it is at this intersection of phenomenology and personal experience and what it means to people and what it means to family or friends affected by somebody who is suicidal. From my point of view, I would say, you know, it's always better to talk about suicide and to share those concerns rather than trying to keep it within oneself or within a family unit. It's always better to share them amongst somebody where you feel safe and trustworthy to do that. And perhaps that's tapping into cultural resources, family resources, or health service resources.
Thank you so much. It's been a distinguished panel. Thank you for cooperating. My apologies for being late. And thank you to the organizers for giving us the extension. And we can see that this will continue to be very engaging. There's so much to divulge and there's so many questions to be answered. Thank you and all the best.
Thank you very much.